Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on rabies. So this is a 3D image of rabies virus, and it's quite uncommon to give you a picture of different viruses and bacteria in your MRCP exam. However, it's a good idea to have a rough understanding on what or how they might look like if this was going to be a question. The epidemiology of rabies is that it is a zoonosis and it is endemic in most parts of the world actually, except in Great Britain, Scandinavia, and Oceania. Annually, worldwide, there are thousands of human cases, unfortunately, and the animal reservoir is mostly dogs. However, it can also be present in other mammals such as bats, foxes, raccoons, or any other mammal that has the potential to bite, basically. Rabies is an RNA virus and it belongs to the family of Rhabdoviridae. Rabies virus travels in a retrograde fashion from the peripheral to central nervous system, unfortunately leading to meningoencephalitis. The clinical features is consistent with a relatively long incubation period of 1 to 3 months. However, it can also be prolonged to even several years. The incubation period tends to be shorter if the bites are on the face of the patient compared to the limbs. And you do get prodromal symptoms that are really quite non-specific with rabies, and this includes malaise, fever, itching, pain, and also paresthesia at the site of the wound. Broadly speaking, there are two different categories of rabies in terms of its presentations. Type 1, which is called encephalitic or furious rabies. This is the most common presentation, and it's basically when rabies causes brainstem encephalitis, and it is characterized classically by paroxysm of generalized arousal and terror associated with hydrophobia in most cases. This is usually accompanied by inspiratory and laryngeal muscles spasms, which is provoked by attempts to drink water. Unfortunately, in most cases, this progresses to coma within days and causes a generalized flaccid paralysis. The second type of rabies that could potentially present, it's the less common type, which is known as paralytic rabies, and this is characterized by ascending flaccid paralysis from the site of the bitten limb normally upwards. The diagnosis of rabies is based on the detection of viral antigen in the nerve ending on the skin biopsy of the affected or the bitten site. If possible, you could also test for the virus on the brain of the suspected vector in here. The management of rabies is really quite poor once this has actually happened and the boat has missed for immunization or vaccination. In the case of rabies encephalitis, unfortunately, this is virtually irreversible. There is no point of involving intensive care in these cases, and the only thing that you could offer the patient is palliative care and symptom management before the days of dying. and it is very important to inform the public health authorities regarding this. In the case of a bite of a suspected animal in an endemic area, it's really important that A, you do not wait for any particular symptoms to happen and you administer the treatment as soon as practically possible. And B, you don't think that in somebody who's had pre-exposure prophylaxis to the virus, that automatically precludes them from having post-exposure prophylaxis. They still need post-exposure prophylaxis. However, normally the length of the treatment that they require is going to be less and it's going to be more efficacious. So the steps you take in the case of an encounter with a patient presenting with a suspected rabies bite is that you clean the wound, you provide passive immunization with rabies immunoglobulin, and you also provide active immunization via vaccination. And you only stop post-exposure prophylaxis in a suspected animal bite if the animal remains healthy for 10 days since the bite, or if you have somehow access to the results of the brain biopsy from the animal that has been tested negative for rabies antigen. So let's do some questions. Question 1. A 32-year-old man is bitten by a stray dog while traveling in a rural area of Southeast Asia. He did not receive a rabies vaccination prior to travel. He presents to the local clinic 8 hours after the bite and the wound is thoroughly cleaned. What is the best step in his management? Option A, administer rabies vaccine only. Option B, administer rabies immunoglobulin only. Option C, administer both rabies vaccine and rabies immunoglobulin. Option D, administer antibiotic and tetanus toxoid only. Option E, observe for symptoms, then consider treatment if symptoms develop. So if you recall, we talked about the importance of providing the treatment as soon as practically possible, regardless of development of any symptoms. Therefore, automatically you should know that option E is completely inappropriate. We also talked about the importance of providing both passive and active immunization, and that would come through administration of both immunoglobulin as well as the vaccine. Therefore, the correct option is going to be option C in here. Question 2. A 34-year-old man presents with fever, malaise, and paresthesia around the site of a dog bite he sustained 2 months ago while traveling in an area endemic for rabies. He begins to exhibit anxiety and episodes of agitation. Which of the following is the most common mode of rabies virus transmission to human? So the options you've got is A, inhalation of aerosolized virus particles, B, direct contact with saliva or body fluids, C, bite from an infected animal, D, contamination of open wound with animal urine, E, vertical transmission from mother to fetus. And this should be really straightforward for all of you. And the correct answer is going to be option C, which is from the bite of an infected animal. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.